батьківщині війна, і мої колеги та друзі зібралися сьогодні для того, щоб розповісти і поділитися своїм опитом з тактичної медицини. Я лікар-хірург, український лікар-хірург. Наразі склав іспити та працюю в німецькій лікарні, але, на жаль, через війну знаходжусь зараз в Україні. Я не маю опиту у військовій медицині. Коли я навчався в Українському медичному університеті, мій батько казав, що Україна – це мирна держава і безпечна держава.
Is a peaceful country and a safe country. For me, it's very difficult to talk right now.
То я з вашого дозволу
If you allow,
зараз представлю моїх колег.
I will introduce first of all my colleagues.
Це Інна, вона лікар-анестезіолог.
She is anesthesiologist.
З Києва. Ми разом працюємо багато років.
We are working for a long time together.
І вона є одним з найкращих
анестезіологів, з якими мені довелося
працювати.
Among those with whom I
Я дуже
had
рад,
a chance to
що вона
work.
сьогодні з нами.
And I'm very happy that she joined us today.
І сьогодні вона також поділиться своїм досвідом.
And today she is also going to share with us her experience as far as TCCC concerned.
Сьогодні з нами також професор Ейб Фінгерхарт.
Today we have also here Professor Abe Fingerhart.
Він мій вчитель з ендоскопічної хірургії. Ми познайомилися багато років тому.
My teacher of endoscopic surgery. We met each other many years ago.
Багато хірургів знають його як колишнього президента.
A lot of surgeons know him as a former president of
ендоскопічної асоціації,
European Association of Endoscopic Surgery.
Я рад вітати вас і дякую, що ви з нами.
I'm happy to welcome you here, and I'm happy that you are together with us.
Також з нами Роб.
Also, we have Rob here with us.
Він медик, військовий медик.
Military medical staff.
From Сполучених Штатів Америки.
From the USA.
І також з нами Антон Осінцов.
And also we have Anton Vosnetsov. He is also a surgeon.
Він з Херсону, але зараз працює багато років в Ізраїлі.
But for many years he has been working in Israel.
Тож я рад вітати всіх вас
на
нашому вебінарі.
I'm happy to welcome all of you at our webinar.
Прошу мого вчителя Ейба Фінгерхарта модерувати цей вебінар.
To moderate this webinar.
Я буду періодично відключатися та модерувати питання,
From time to time,
які
I'm
виникають
going to switch off my camera and just to moderate the questions
на нашому стрімі у Ютубі
we have in our stream in YouTube and on Facebook.
Тож, за планом,
according to our
перша
plan,
доповідь буде
the first
у Роба.
presentation is going to be carried out by Rob.
Дякую за увагу.
Thank you for your attention.
All right, good morning. Got some slides that have been modified to the situation at hand. These are mainly the slides I will teach to my soldiers. But with the experience that is in this, I've kind of changed them just a little bit. Let's see here. Are you all able to see my screen yet?
yet.
Oh, are we able to do screen sharing?
Yes.
You should have a button on the bottom of your
Yeah,
screen.
it says it's disabled by host.
But then you have to find the screen on the, you have to click on the screen that's under the, among all the icons that you have on your screen.
Try again.
Go. All right. All right. So
There we go. Yeah, we got it.
awesome. All right. So I've been doing this for quite a few years now. About 12 in the Army, 6 before that in the civilian side. We've just the U.S. Army has just released Tactical Combat Casualty Care to the general public within the last 2 weeks, I think. So I've kind of put together some of what we go through. Our Tactical Combat Casualty Care is actually made up of 3 phases. The first being care under fire. While you are still in a threatened environment. Once that threat is eliminated, then you move into the tactical field care, and that's where our job really comes into play. That's where you're going to get the majority of your care, and then all of that is setting up for tactical evacuation to a higher echelon of care. During the care under fire phase, we're just going to cover this real quick so that we have a broader understanding. But during care under fire phase, we don't do any work that's medical. The patient, the casualty, may apply a tourniquet, may do direct life-saving interventions on themselves. If that is not possible, we're going to attempt to suppress any threats. We're going to attempt to keep them fighting if they are available to suppress that threat. And then once they are able to, once someone is able to move to them safely without taking more casualties, is when we will actually go pick them up, drag them back, behind cover or concealment, depending on where they're at. And it's basically just grab and go and treat. You're trying to get them, you're trying to do any life-saving interventions that can be done right then and there without causing you to become a target as well. You're going to, once the threat's eliminated, though, is when we move into the tactical field care, TFC phase. And our main goal there is to avoid putting them anywhere in the lethal triad. Hypothermia, coagulopathy, and acidosis all play off each other when it comes to trauma patients, especially in a battlefield environment. They are, just exactly what it shows. They all feed off of one another. If you start declining in one, it's going to cause a round robin effect, affecting all the others until you no longer have a patient. Once we are in the care or the tactical field care phase, we run off of the SMARCH algorithm. The first being security, that is going to go all the way through. If you have the manpower, it's very comforting to have people watching over you while you are working on your patient. We generally try to send somebody out to kind of watch the medics back, because generally there's only 1 to 2 medics for a large element. So if one or both medics go down, now you've lost a key capacity of keeping your soldiers going. After security, and as I said, security moves all throughout this. It's something we reassess as much as possible. But after that, it's massive hemorrhage, airways and adjuncts, respirations, then circulation, then hypothermia and head injury. I'm not going to focus much on head injury in this presentation. Again, for security, you should be looking for cover concealment, shouting at your patient, either treat themselves with a tourniquet, play dead, shoot back, whatever they are capable of doing, they should be doing themselves. If not, you minimize that threat. Attempt to send somebody else. If you've got somebody else who can go get them and keep you behind cover or concealment, it's best practice to do that, again, because if you go down, now you've got 2 patients and no medic. Cover is going to be anything that's going to stop bullets or projectiles. So concrete walls, brick, armor plating, large rocks, things of that nature. Concealment is anything you're just going to be able to hide in. It won't stop bullets, but you are able to hide in it. I tend to use smoke quite a bit. Smoke grenades. If I don't have anything else, I'm going to start dropping smoke grenades to at least conceal my movements, conceal where I am. Now, if anybody's shooting at us, they're shooting blind. Again, always maintain situational awareness. Be thinking of your next cover and concealment position in case your current one is compromised. Just keep that in the back of your mind that you may have to move, so you want to know where to move to. So moving on, we get the patient back. We focus on massive hemorrhage. The battlefield deaths, uncontrolled extremity hemorrhage has been the leading preventable cause of death for casualties for decades. Arms, legs, those are absolutely preventable. Most people have on them what they need to prevent that. It's a matter of getting a tourniquet on that limb. When you're in the massive hemorrhage phase, you are looking to go high and tight. We go as proximal to the trunk as possible with bullet wounds, shrapnel wounds, blast wounds, anything like that. A lot of the wounds we see in combat, they may not look as involved as they are, meaning you've got an entrance wound somewhere that may not show how bad it really is, because you're going to have a lot of constriction, and the arteries and veins can actually retract temporarily. It's a shock factor. They get shocked and they will suck up into the limb. So we put a tourniquet as high as we can, either at the shoulder or at the waist, as high as we can for the time being, because we will come back and reassess the tourniquet and any interventions that need to be done later on in the circulation phase. But for the time being, our main concern is to get the bleeding stopped so that we can move on to airway and respirations. The big thing I've noticed in my time in is a lot of times with IED blasts, gunshot wounds, you may not notice a lot of blood initially. I've seen medics come up and go, oh, well, you know, we'll just wrap that in gauze in a few minutes. And what has happened is that artery or vein has been lacerated. It constricts and so it's not bleeding very much. So they think, okay, moving on. And they come back later and realize you've just lost 4 units of blood because that artery stopped constricting. So like I said, if there's any suspect of needing a tourniquet, of vasculature compromise, you're going to go ahead and do that tourniquet and reassess it in just a few minutes once you move on. These are some of the commercially available tourniquets. This is the combat application or the CAT tourniquet. This is what we use. Now I know I did see last week that a American company, North American Rescue, was putting together quite a few first aid kits that are individual first aid kits that will go to people on the ground. This middle one here, this combat application tourniquet, is what will come in those, more than likely. Top right is the rat tourniquet. They will work in a pinch. I don't even actually carry any of these. It's too much risk for the ability to use anything else. And then right below it is the soft T tourniquet. These are my preference, at least for my line of work. The problem with the CAT tourniquet is if you don't get cinched down all the way before you start spinning this windlass here, if you don't get cinched down all the way, you end up spinning this windlass and spinning it, and it puts a lot of stress in the middle of it. These windlasses can break occasionally. The soft T tourniquet is made of aluminum and heavy duty nylon. I have yet to break a soft T tourniquet. For an improvised tourniquet, we just have, we're gonna have you pack on gauze, wrap it, tie half a square knot, tie something stable, sticks, metal rods, anything like that. You're gonna tie that into the first half of the square knot, then tie the rest of your square knot over it, start spinning it, that whatever that stable thing is, it's going to act as your windlass, and you're going to end up tying it down with another cloth. It's all fairly simple. One of the big things though, for tourniquets, you want to mark somewhere on the casualty that a tourniquet was placed. Our standard operating procedure is we will write a T on the patient's forehead along with the time it was applied. That comes in to play later on once they reach a higher echelon of care. It also, if we cannot evacuate them, we will reassess as the hours go by to see if we can release that tourniquet just to prevent tissue death further down the line. I've got a couple of videos here that are not going to play. Let's see. Just one moment. I'm pulling them up.
Robbie,
Yes.
can you open please demonstration of the screen? If we will see just only one slide, it will help for you to open the video. As we see all slides from the left side from the screen, it is why, like, open for demonstration.
Yes.
And after, yeah, exactly. And after, no, a little bit right. This one, yeah, exactly. And put it right.
Thank you. Thank you. All right. For today, we're going to simulate that our patient has a lower leg injury or amputation requiring a tourniquet. We're going to go high and tight with it because this will still constitute care under fire. For tactical field care, later on, once your enemy is suppressed, once you're out of the threat zone, then you can move tourniquets. But for now, we are doing a high and tight on our patient with a right lower leg injury or amputation. This tourniquet is fresh out of the individual first aid kit. to loop it around. Always have your tails pointed toward yourself. We're going to get it up as high and tight as we can. When we cinch it down initially, we're going to pull this buckle, hold this one, and bring it taut. Wrap the tail around. We're going to turn until we see blood flow stop beyond distal to the injury, or until there's no distal pulses. Once you tighten this, it is going to get uncomfortable, so pain control is a good idea if you have the resources. But you'll tighten this. Once it is tight, blood flow is stopped, no distal pulses, you'll go ahead and secure this down. I personally like to tape mine afterwards. And then you are going to mark on the patient's forehead using permanent marker or whatever you have, a T and the time the tourniquet was placed. Included is it's the exact same for the upper arm. All right, so once we have the tourniquet in place, bleeding has stopped, you're going to go ahead and move on to airway. The two interventions that can be performed by non-medical, we train our guys to use the Nasopharyngeal Airway or an MPA, or simply place them in the recovery position that's on their side to keep them from aspirating blood, vomit, whatever. The goal of this airway stage is to ensure patients have an appropriate, a patent airway that will support their breathing. That's really all we're worried about. For conscious patients, they should be allowed to assume a position of comfort that allows them to breathe comfortably. This is really my big thing when it comes to maxillofacial trauma. A lot of times you will get folks who they have maxillofacial trauma and they can breathe on their own if they're sitting up, but for some reason medics tend to want to lay them back to work on them because that's what we're used to. If you sit them up, they can maintain their own airway, and they can maintain their own airway until they can't, and in which case is when you take over. Patients with questionable airways or airways that may become compromised, we're going to evaluate them for nasopharyngeal airway or an oropharyngeal airway. I'm not a huge fan of oropharyngeal, but the nasopharyngeal airway, really, with most head injuries, I won't use that because you can cause further damage if they have sinus compromise. The airway adjuncts we use, the recovery position, the oropharyngeal airway, the nasopharyngeal airway, and then really where you get to the medical aspect of it, the medics who are on the ground, we should be carrying at least supraglottic airways, either combi tubes, King LTs, or the iGel. I'm a huge advocate for the iGel. I've used them multiple times, and every time they are so easy. We generally have found that the size 4 to 5 iGel will fit almost every fighting age male in at least in our experience. Following that, if that's unavailable, we're going to move on to rapid sequence intubation. It's discouraged in a technical field care environment just because so much extra equipment. Now you've got a patient who may be sedated, and it causes a lot more issues. You've got to have a lot more equipment and a lot more personnel to have an intubated patient. And then I say our last line is surgical cricothyrotomy. It's not our last line. There's a lot of times where we will jump to that. If you've got burns, facial burns, facial trauma that you may not be able to intubate through. If the I-gel won't work for whatever reason, we're generally going to go ahead and do the surgical cricothyrotomy. It's one of those things where experience has to outweigh nerves on that one, though. Is insertion of an
For
NPA.
patients having problems maintaining their own airway, you may think of using a nasopharyngeal airway. It's in most aid kits. This will simply bypass through the nose and bypass the tongue to allow the patient to breathe, even if their tongue has rolled back in their mouth. It's one of the most minimal airways we can do. So you're going to take your NPA, you're going to measure it, make sure that it's not too long or too short. So from the tip of the ear to the corner of the mouth is the general rule. When you insert it, it's cut at a bevel. You'll go bevel towards septum. I will use the patient's right side. You're going to lube it up. They usually come with a packet of lubricant. You're going to use your non-dominant hand to pull their nose back just enough that you've got a straight shot in. You'll insert it again, bevel towards septum, and drive it in. If the patient starts to gag or vomit, you can go ahead and take it out. You will continue pushing it. If they are conscious, you can have them swallow while you are advancing the airway. And once it is flush with their nose, then it is fully seated. You can tape around it to maintain it in place. I don't like to, though, because if they start gagging or anything, it will help unseat itself and they easier to take out. This is good for patients with problems maintaining their own airway, just as long as they don't have facial injuries.
And then I don't know how familiar you all are with the I-gel. As I said, it's one of my favorites. Super easy to use, small enough that I actually carry multiple I-gels in my gear that is on me.
For a patient that needs a more definitive airway, cannot tolerate a nasopharyngeal airway, or you think is going to crash, one of my favorites to use is the I-gel. Now, these are measured in different sizes. They're simple to use. All you're going to do, if your patient is unconscious, has no gag reflex, you're going to just slightly hyperextend the neck. You'll go ahead and move the distal end. I personally like to use my thumb on my non-dominant hand to grab the tongue. Now this is lubed. I am going to place this into the patient's mouth against the soft palate, and I'm just going to advance it, riding that soft palate back until it seats itself. Once it seats itself, you can go ahead and attach your bag valve mask and breathe for the patient. And aside from securing it, there's not much else you need to do to it. It's easier than intubation, quicker than intubation, and much easier to extubate them as well.
Years ago, I had a instructor that told me if you don't have an airway, you don't have a patient. It's absolutely true. Moving on to respirations. Once you secure an airway, you're gonna make sure they're maintaining adequate respirations. 12 to 20 is target with equal bilateral rise and fall of the chest wall. Hyperventilation or hypoventilation it'll affect the lethal triad, causing acidosis and eventual death to the patient. Hyperventilation, hypoventilation, right here. Hyperventilation causes carbon dioxide retention, causing acidosis, and then hypoventilation may not sustain life. If your patient is unable to support their own airway, the medic needs to assess assets versus necessity. And what this means is if I've got 10 guys with me and none of them are medical besides myself, and I've got a patient, I can still have one of those 10 guys utilize the bag valve mask for my patient. Look up and find the least dumb one and say, hey, you're going to squeeze this bag every 6 seconds, all the way, squeeze it and let it go until I tell you to stop. If you don't have a ventilator there, using your assets is a great option. If you've got a mechanical ventilator, that's even better. But along with that come its own problems. You have to know what settings you're using, how that ventilator works, what the battery life is, and that ventilator is going to be on that patient until either the ventilator dies, your patient is gone, or they've moved to a higher level of care. In a tactical situation or mass cal, breathing for a patient may not always be an option for the medic. Mass cals or tactical situations that we may have to move or work something else out while that patient is needing respiratory assistance. Again, that's when you assess your assets and make that decision of whether you're going to control their respirations, whether you're going to have your mechanical ventilator do it, or whether you're going to have someone else altogether do it. Chest seals. So one of the big things in a combat zone is penetrating chest wounds. Anything from the clavicle to the navel gets a chest seal just for how deep the diaphragm goes. When the diaphragm is retracted, it sits right under the lungs and right under the rib cage. When it expands, it comes all the way down to the navel. Now, your iliac crest or the top of your hip bone is right about here, and a bullet or fragment hitting that and bouncing up through it is going to open this pleural space in between your lungs and allow air to get in, which is going to cause eventually a tension pneumothorax. We've got our chest seals here.
All right, to apply the chest seal, we're going to simulate that our patient has a gunshot wound to the right upper chest. First thing I'm going to do is I'm going to go ahead and attempt to dry off any blood, sweat, water, open my chest seal. If they are extremely hairy, you can use 2 chest seals. What you'll do is you'll take the first one, apply it, and tear it off. That will clear all the hair off of the skin. I'll remove the backing. Normally, I would go ahead and place a hand over the hole. But you're going to go ahead and apply the chest seal like so, making sure that all 4 sides are down. If they are alert and conscious, you can have them exhale as you do it. Once I've applied this one, I want to make sure that it's not a through and through. So I'm going to roll my patient over, check for exit wounds out the back. If there are, I'll go ahead, place my hand over, prep another chest seal, and go ahead and apply that. We're going to make sure it stays in place and move on with our assessment.
Patients with penetrating chest trauma should be monitored closely and reassessed continually to monitor for either pneumo or hemothorax. You're going to monitor by that by rate, rhythm, difficulty of breathing. If they're conscious, you can ask them. You're looking for equal bilateral rise and fall, listening to lung sounds, monitoring your O2 saturation, just all of this all of the time. Tension or pneumothorax is air within the pleural space of the chest, basically crushing your lung. Hemothorax is blood inside that pleural cavity. Both of them are pretty easily treatable. on the battlefield. Your hemothorax, you're going to do a finger thoracotomy, but the pneumothorax is the easiest. We carry a needle chest decompression kit, which is basically just a large needle that you will cover here. It's going to be either a 14 or a 10 gauge, 8.25 centimeters. You may need to use multiples of them. They tend, at 14 gauge, they tend to clot pretty bad after a few minutes. So once you've got that chest sealed off, you can decompress it using that needle. It may need decompression again. It probably will need decompression again. So you have to either flush it with about 2 cc's of saline, or you can just apply a whole nother needle. And you're going to work anywhere on the third rib. So you're going to find the clavicle, work your way down to the third rib. Once you find that intercostal space between the second and third rib, you are going to actually place it closer the top of the third rib and ride that rib in. It's going to be a 90-degree angle into the chest. And you're riding the top of the third rib because underneath each rib is a artery and vein and nerve bundle, which is going to cause massive bleeding, permanent damage if you damage the nerves. So we tend to try and ride the top of the rib. If for some reason you can't use the mid-clavicular line, you can work from mid-clavicular to mid-axillary line, anywhere in there on that third rib on the affected side. Oh, that one's not going to work. Moving on. All right. Again, your respiration should be monitored closely on all your patients that may have respiratory compromise. Bag valve mask is the minimum equipment with any patient that's in respiratory distress. It's going to lead to respiratory failure. Ventilators, Untitled CO2 monitors, PEEP, PIP, they're all suggested but not required. But you're going to get better results using those. You can use your assets at hand to assist with respirations and ventilations. Again, you can use non-seriously injured patients. If you've got a mass casualty issue, you can use your walking wounded to breathe for your patients that need it, or other soldiers. Basically anybody you trust, you can use. So moving on, once we've got respirations controlled, and through respirations, you're also going to annotate your rate, rhythm, and quality. It's going to go into the vital set that you're continually taking, just to start trending your vitals. Moving on to circulation, you're going to check and repeatedly check throughout the care of the patient the circulation. You're looking again at rate, rhythm, quality in all limbs, affected or not. A lot of times the minimum pulse pressures will come into play. I don't need a full blood pressure if I know that they're still maintaining a radial pulse of 80. If they lose their radial pulse, I understand that with a jugular pulse of 60, they are still perfusing adequately enough to not cause any permanent cognitive damage. Radial pulse also comes into play here in just a few minutes when we give either blood products, tranexamic acid, clotting factors. We are going to give them in a battlefield condition. We are going to give those just until we get a radial pulse back. We are pulling them out of shock with that, but we are not going to cause circulatory overload. So if a good rule of thumb is push your product until you get a radial pulse back and then titrate as needed to maintain at least a radial pulse. People get hung up on IVs. And if you are not practiced in IVs, it is difficult, especially in the back of a moving vehicle, in low light conditions. There's a lot that factors into getting good peripheral lines intravenously. And so always keep in the back of your mind that an intraosseous infusion is almost just as good as IV. I will take a quick IO over a slow IV that's going to hold me back. My rule with all of my guys is, if you cannot establish a line within 30 seconds, establish an IV line within 30 seconds, you're going to go ahead and initiate the IO. You're going to do more damage wasting time attempting to get that IV than you will by just sticking an intraosseous infusion through either the tibial plateau or the humeral plateau. This is just a quick little one.
He prepares an IO, a needle that delivers blood straight into the bone. IO is in. Blood flows into the critically wounded soldier, a potentially life-saving intervention.
For the IO, you can push blood products through it. You can push fluids through it. You can push medication. Anything you can push through an IV, you can also do through an IO. Although with an IO, you're going to have to use more pressure behind it. So we generally carry pressure bags as well. During the circulation phase, where you're going to consider TXA or appropriate blood products for hypovolemic patients. Right now, the the Joint Trauma Systems is in the midst of testing a couple of theories, but right now 2 grams of TXA, slow IV or IO push within 3 hours of injury is the best practice. You're going to dilute it in 100 milliliters of normal saline, slow push over 10 minutes or so. If you cannot dilute it in saline, you can straight push it and follow it by a saline flush. It's better practice to dilute it and run it over time, but if time's not going to permit that, and that's just going to cause that's just going to assist the coagulopathy of the patient's blood. Personally, I prefer to use blood products if available. I know right now in some contested areas, blood products may not be as readily available as they are, normally. But if you have the option, whole blood is always going to be your best, your best choice. Right now, I know several places are researching and finding that low titer O-neg whole blood is your best bet, and can be pulled from quite a few people right then and there and turn around and put back in another patient. If you don't have access to whole blood, then plasma, platelets, and red blood cells in a 1-to-1-to-1 ratio. If not that, then plasma and RBC and red blood cells in a 1-to-1 ratio. If not that, then plasma or red blood cells. Otherwise, you're going to get into, if you've got none of those, then you may have to move on to fluid therapy with normal saline, Ringer's lactate. If you do use blood products, calcium administration is going to be necessary eventually. Preferred calcium gluconate, it's better on the surrounding tissue, and 1 gram administered after the first unit of blood, followed by a subsequent 1 gram dose after every 4 units of blood. And then again, that blood administration should be titrated using pulse pressures. I like to maintain a radial pulse of 80 to 90 palp. The reason for that, anything above that, you're going to start blowing those clots out that, or you can blow those clots out that you're putting blood in to help assist with. So you're really negating yourself by pushing too much. And then if you get them, once you get them up to 80 to 90 palp, then you can go ahead and start fluid therapy with isotonic fluids. Moving on, after circulation, you're going to go to hypothermia prevention. And while we don't touch on this much, it's pretty simple. It's one of the easiest things to screw up. Letting your patient get cold is going to affect that lethal triad. Hypothermia is going to cause coagulopathy issues. And the cycle just repeats itself. So you want to initiate this as early as possible. Best practice is, while you're moving your patient to the litter, throw a blanket under them. Once you have done your assessments, you can go ahead and wrap that blanket around them, and you've already got them wrapped up, and you're not going to have to move them anymore. To prevent hypothermia, you can use heat blankets, warm IV fluids. You can use the environment. If you're outside, bring your patient inside. Blankets or sleeping bags. And then if you absolutely have to, you can have buddy warming. Basically, have somebody who is uninjured come over and wrap them in a big hug, basically, just to keep them, just to utilize that body warmth between the two of them. Hypothermia management is one of the main things that people forget. They get going and they want to reassess those vital signs, and they forget to cover that patient up. And now all of a sudden, because of the hypovolemia from the trauma, now your patient is hypovolemic, so they're having trouble maintaining their own. They're having troubles thermoregulating, and now you're crashing them through the floor. It's super simple to look past, but it's also super simple to fix. After that, you're going to go ahead and prepare them for evacuation. Hopefully by this time you've got an evacuation plan. You are going to continue reassessing vital signs every 3 to 5 minutes. Every time you move your patient, you're going to reassess your interventions. Make sure that tourniquet didn't loosen up. Make sure they're not bleeding somewhere else. You want to get them out of your care as soon as possible, just because if you are sitting on a patient, that makes you're moving slower than everybody else, so that is going to make you a target. Document what you're able to. I don't know what other units do or other countries do, but we like to send them with something showing what we've done, what their injuries are, especially when you've done all these treatments on them. They're wrapped in a blanket. Whoever's taking them from you may not know that they have a tourniquet somewhere under that blanket, or they may not know that you've packed a wound and have it. They may not know to check that. So documentation is big, as well as communication with whoever you're passing your patient off to. Like I said, plan for your evacuation while you're doing your treatments, flight versus ground, time frame, and the time that evacuation is going to take, and the capabilities of that evacuation platform. So you've got to know, if you're flying them out in a helicopter, you're going to have to do different interventions than you would with ground capabilities, as well as that affects the time frame and their time to a higher level of care. So you may need to put some extra work in to get them safely to their next place. Also, another thing to evaluate is things you may need your evacuation platform to bring you. If you've just used whole blood and that's all you have at whatever facility you're working with, it doesn't hurt to ask the incoming evacuation to bring more whole blood or a ventilator, because they're going to need a ventilator to transport that patient, and you need to keep yours. Spine boards, litters, any extrication equipment you may need for this patient, just things like that. And then that pretty much concludes it. Are there any questions? Yes.
Okay, Robbie, thank you very much for your information. Just for information, then starting from 2014 in Ukraine, we organized course for our civilian and military doctors, and we called it UTLS, Ukrainian Trauma Life Support. And we already use this protocol March in our teaching process without letters S, I mean security. So my question is, as I'm an anesthesiologist, and many doctors also will have a questions about fluids. How many fluids, I mean normal saline, can you give like a bolus? And what do you know about bolus on the field? I mean, what do you mean? For example, in Ukraine, unfortunately, we don't have enough blood products, especially on a field. That is why, what can you say for our doctors about fluids? Several words, please. Thank you.
So, normal saline, let's see, we'll run up to 2 to 3 liters of normal saline through a patient. Going on 3 liters, you have a tendency to overdo it. If you can't get a palpable radial pulses back with 2 liters, it may not be doable in battlefield conditions. Without whole blood products to help that, it's really, it's almost a guessing game. It's uncomfortable, but you've got to weigh what you have supply wise versus how much this patient is going to take. If it's going to take me pushing 4 liters of fluid, well, I'm going to push them into circulatory overload with that. And now things like respirations comes into play when you're drowning your patient just to get fluid in them. So our rule of thumb isn't necessarily a number. It is trying to get that radial pulse back and maintain that radial pulse. So, 1 to 2 liters is going to be pretty much your max before you're looking at other options. Because also, when you're on the ground, you can only carry so much with you. So in a hospital environment, that may be different. If you've got other hands, TCCC was made more for the singular medic or small unit medics who are carrying everything on their backs. So yeah, we go with return of radial pulse, and that's a good indicator of where you should titrate your fluid therapy to.
Rob,
thank you very much. Okay, just a second, please. Thank you very much for this information. As you know, sometimes it depends also how long we have to move with our patients. And sometimes if patient has no signs of head trauma, we use also permissive hypotension. It means that we don't give a lot of fluids, just take a radial pulse and think about permissive hypotension is we think about also, for example, intra-abdominal bleeding. Okay, thank you for your information. Any comments?
Okay. Rob, thank you for your very interesting lecture. One small question. If every military doctor on USA must have nice cuckoo sleeves on your hand.
Okay. I'm not a doctor.
Okay, Rob. Sorry, I switched to Ukrainian language for our auditory. Kirill, it's okay?
Yeah.
Я хочу перейти розмовляти українською мовою. Кирил, чи можна
I would like to move to Ukrainian language. Do you have the translation into English? Could you please confirm that you're on the English channel and you hear the interpreting?
Yes, I hear the interpreting.
Thanks. I'm a surgeon. I was born in Kherson, and I have been working in Kherson for now. I have been for 20 years in Israel, and I would like to give some remarks. Sorry, my Hebrew is on. About different aspects of TCC and TFC. About the tourniquets. Rob was saying that it's critical to write the time of the application of the tourniquet. We understand why it is so necessary. In Israeli army, we are writing the time of the tourniquet not on the paper, but on the forehead or on the arm, on some place where it won't be forgotten or lost. I heard the question from the anesthesiologist about the rules that the practice in the medical medicine is different from the civilian one. That there is no space for the indirect heart massage. So it's not a question. So if we have a hemorrhage, and if we are doing the heart massage, we are only assisting the bleed. Another issue. In the Israeli army, it is forbidden to have the bandages of the open injuries of the chest. It could be something even from the cigarette box. It should be sticked on the three sides. So the open hemothorax than the tension hemothorax. We've heard about the needle application. And you also heard about the blood injection, but we do not use fluids. It's not our goal to infuse the fluid. Because it dilutes the close factors and it increases the hemorrhage, the bleed. That's why we do not use the fluid in hemorrhagic study. No fluids, no Hartmann, only blood.
It's what I want to speak about. Sorry.
Dear Anton, I didn't ask about CPR during trauma. I thought about exactly about fluids, as because unfortunately for now in Ukraine, I'm just trying to find a lot of tourniquets. Is it the first? It's really a problem for our country, as we bought a lot of tourniquets, but we are waiting now from Poland, from Austria, from Germany, as it's now there is no possibility to buy it in Ukraine. It's really our problem for now. It's the first. It's true. The second one, that there is no possibility to use IO. And the third one, we know about clotting and hemodilution, as because we saw on the slides about triangle of death during the trauma. That about fluids. And these 2 liters helps to save lives for our soldiers, for our militaries, as because we have no for now possibility to use blood products on a field, just only in the hospitals. This is the problem. That is why I thank you very much for Robbie about answer about 2 liters. We need, you know, the time to move to the hospital and to give proper treatment for our militaries. So, of course, blood products, of course, no CPR. We know about this. Thank you very much. But problem that we have no possibility to use blood products on a field, unfortunately. Yes, and may I put another question? Probably it will be interesting for our also doctors. You know that in Ukraine, we have a special devices, as for example, if we use tourniquets, so we use it just only for arms or legs. But also in Ukraine, we started to use several years ago special tourniquets. I mean, like if we think about trauma of TAS, I forget with their
pelvic trauma.
Yes. And maybe several comments, please, about neurological assessment, please. Okay. About neurological assessment on a letter hypothermia and head trauma. Quickly, neurological assessment. How you recommend it to do on a field for our doctors? Thank you.
So neurological assessment. You're gonna have to make an educated guess. Now we'll do this with a scale of alert. If they're alert and talking to you, that's best. Whether they respond to verbal prods or painful stimuli, or if they are completely unresponsive. Hang on, I actually may have something here.
Ina.
So I mean that Robbie thinks about a VPU scale, alert, vocal, pain, and unresponsible. We also use this scale in Ukraine, exactly. Yes, and you know the problem that we still have no IO devices, unfortunately. That is why mostly we usually just IV, peripheral IV access. So, and you know, in previous protocol of trauma combat casualty care, we use first 1 gram of tranexam, and after the second one during another 8 hours. As I see that we can see some changes about 2 grams at the start. So yes, probably it's important, makes sense, but quickly bolus of tranexam acid can cause hypertension also. That is why we also use yes, that's why
you try and do it over a slow push over about 10 minutes if you can. But that hypotension is just refractory hypertension. So if you're expecting it, you may be able to fight it off and maintain your patient.
Я розумію, що наша аудиторія це лікарі.
I understand that our audience is the doctors, but the things which Rob was talking about, which every person who has a elementary medical education can do. Your questions are the questions of the doctor. But what Rob was telling, that the basic things, the first aid, the doctor who is acting at the battle, the neurological assessment. What will we do with the neurological assessment? We have first to check whether the person is conscious, whether there are reactions. But it's important not for the neurological assessment. Для перевірки верхніх for the airways, whether they are obstructed or not. What you would like to know more about the neurological assessment? What will you do with this if you see that the person has some neurological deficiency? What the courseman should do with this? We are speaking about the saving of life. I believe that's the most important in this point. If there is a neurological deficiency, and the person who is providing the first care can define this, then this person should be placed on a flat surface, and that's everything we can do in this situation. Everything you are asking is already in the hospital. Now, our topic is a bit different. We're speaking about the battlefield, about the combat area. I'm asking these questions for those who are asking, because mainly the doctors who are later training.
В Україні, for our military course in Ukraine, it's called CLS, Combat Lifesaver. So, and during the course of Combat Lifesaver, we teach our military to put nasopharyngeal tube, to use IV access, and to use tourniquets, no more. Another all courses, except of CLS, Combat Lifesaver course, was exactly for doctors and medical instructors on the field, and mostly they are doctors, unfortunately. That is why I put these questions, just to make our conference to open for our doctors. So that is why we meet each other here. I think so. Just put questions. Thank you.
Протоколи ATLS, Advanced Trauma Life Support.
The protocols of ATLS are the protocols, pre-hospital protocols. These are the protocols from the battlefield to the hospital. In the hospital, there is no ATLS anymore.
ATLS, Advanced Trauma Life Support, якраз в лікарні. А все, що до того, it's a pre-hospital trauma. Ну,
The hospital. And the other is pre-hospital. But yeah, nevertheless, I just want to explain the neurological issues, because it's very important, the concept of supporting the blood pressure during the transportation of the patient, because in case of craniofacial cranial-brain trauma, we are trying to keep the blood pressure at level of 90 or higher, even with other traumas. Can we make such suggestions and recommendations to our doctors? What can I say for your doctors? That the brain trauma during the combat, or if it's either the soldier is going to die or there is enough time to transport the patient to the hospital. Because there is no time to measure the blood pressure, arterial blood pressure. Even if you don't measure it, he will not die. So the measuring of the blood pressure, it's a different thing. Yeah, you are right completely. If the patient is in the hospital, you have to measure it. It's 100% truth.
There is a place for antibiotics, early using of antibiotics, and analgesics. So, Robbie, can you give us several comments about antibiotics and analgesics, please?
So for analgesics, we use actually due to supply issues as well as what we currently have, we basically use ketamine for quite a bit. We will start for analgesia, we will use a loading dose of approximately 80 to 100 milligrams of ketamine, slow push. And a lot of times you will take your preloaded 100 milligrams of ketamine and slow push until you see nystagmus. Once you've reached nystagmus, their pain is controlled. Now, ketamine is not the greatest because its half-life effect is short. However, with ketamine, I don't have to worry about the respirations of the patient as a secondary to, you know, pushing opiates, fentanyl, morphine. They affect respirations. And so that's a whole nother issue that you're getting into with just with analgesia alone. Like I said, there's a lot of units that are going strictly to ketamine for pain control, for major pain control and sedation. Now you back that with 2 milligrams of Versed, either as you're pushing that ketamine or immediately after that ketamine is pushed. And while they're both short acting, they do tend to work well with each other for sedation, as well as the reason ketamine hasn't become so popular in America, at least up until, you know, the last few years, was because of what we called the K-hole. People reach a certain point where that ketamine is therapeutic for pain, but causes psychosis. I don't know how to describe it, but it's a terrible feeling that they are helpless, but they're feeling this or dreaming this. It's almost like a psychological thing. But they've noticed that if you pair approximately 2 milligrams of Versed with that ketamine, you are less likely to have them have negative interactions with the ketamine. We still do use morphine and fentanyl. It's just not as widely accepted. As for antibiotics, we currently may start Invans, ertapenem, if we're going to be in a delayed evacuation status, but normally on the ground, we are not going to start antibiotics. That is more of a hospital thing. Again, tactical combat casualty care was not made specifically for a clinic. It's more titrated to the medics who are out on foot and carrying all of their gear on their back. If I can save weight by not carrying antibiotics or carrying minimal supplies and have a, we call them the speedball, but a ready bag of other things we may need that can be dropped off to us with the incoming evacuation platform, or, you know, another unit that's coming in, I'm going to carry just enough on my back to maintain maybe 2 patients. Antibiotics does not fall into that because that's taken up room. That's taken up, it's taken up room that I could be using for immediate life-saving supplies. Now, while antibiotic therapy is important, it is not something that I am willing to risk weight and space over when I'm just going to evacuate them, you know, within the next 4 hours anyway, and someone higher up can get a more narrow spectrum antibiotic, something that's probably going to be better for them in the long run.
Why I'm asking is because we also have a problem with the platform for evacuation, and I put question about painkiller. As you know, for now we don't have morphine there. That is why could we use non-steroids anti-inflammatory drugs during evacuation, or paracetamol? It's okay also, I think. Okay, and also we still use ketamine on a pre-hospital. Thank you very much for your comment. Thank you.
Mhm. And one of the things I wanted to add earlier was aside from monitoring their alertness, we also will use the Glasgow Coma scale. I don't know if that's something used throughout the world, but the Glasgow Coma scale. And you know, we've got a saying that if their Glasgow is less than 8, we're going to go ahead and intubate. If their Glasgow Coma scale is less than 8, or it's, you know, starting to drop towards 8, we are going to start monitoring when we're going to have to put in an airway and breathe for them and things like that. But that's as far into it as we get with neuro is monitoring that and watching for a downward trend in it.
Кирил?
У мене ще було одне запитання, якщо дозволите.
I have one more question, if you allow.
Absolutely.
Just surgical question about the tourniquets. Is there any difference from the point of view of the location of tourniquet placement, depending on type of trauma, whether it's a gunshot or it's explosion of the mine, debris, etc. And the second part of the question is about changing the tourniquet. When can we change the tourniquet, and when and how to exchange the tourniquets?
So we do not, for your care under fire or your massive hemorrhage sweep, you are going to go as proximal to the core as possible. Due to the way some injury patterns present, you may not be able to see the entire injury, and so we want to isolate it as best we can. Now, when we come back in the circulation phase, and I'm sorry, I missed putting that slide into this deck. The circulation phase is where you assess if you're going to change from a hasty tourniquet to a deliberate tourniquet. Now, hasty is always going to be high and tight, close to the core. Your deliberate tourniquet, that is where you're going to analyze the wound. Your tourniquet can go 2 to 3 inches above that wound to save as much viable tissue of, you know, that extremity as possible in the long run. You'll put 2 to 3 inches above the wound, tighten that down, and then you can start changing out your tourniquet. Now that comes, if it's safe to do, in the circulation phase. Otherwise, it's going to be somewhere down the road past evacuation, depending on your time frames. A lot of this kind of goes hand in hand with delayed evacuation casualty management, which is a whole different course entirely, with a whole different rule set. But we like to try and get a hasty tourniquet transferred to a deliberate tourniquet within that first patient assessment, if possible. Converting tourniquets, at least our standard operating procedures are, it is only the medics who do that. It's not our everyday combat lifesavers, but our medics may be able to, but if they are not confident enough, if they don't know, we're not going to press them to release tourniquets, you know, with wound packing and compression bandages if they're not comfortable and knowing exactly what they're doing, because aside from the blood loss, you also have the issue after time with a tourniquet, you're going to have compression injuries. And so a lot of times our guys will just leave the tourniquets on, even if they don't need it, because the medicine we are taught is meant for here in the combat zone, and move them out and let somebody else deal with it. Now, while that's not always the correct answer when you're dealing with mass cals or, one medic to 30, 60, 100 troops, it's required to keep them able to treat as many as possible. So yeah, during the circulation phase and the reassessment phase of March, reassessing the algorithm later on down the line is when you're going to decide whether you are removing a tourniquet or going to keep it on or remove it.
Дякую за розгорнуту відповідь.
Thank you for a very detailed answer.
Якщо немає більше запитань,
Dear colleagues, if there is no question, well, there are some.
Several words about tourniquets. As we know, and I still to talk about this during all our conference, that we have a problem with the evacuation. It means that that guys who take this patient from the place of fire and evacuate him should think about tourniquets. And there are some rules about long period of tourniquets, above 4 hours. It should be, so during evacuation, medics can start to remove tourniquets under control of bleeding, visual controls, not pulse. And if it still bleeds, they turn tourniquet again and move with it. If they try to remove one scrub of tourniquet and there is no bleeding, they can remove it during the evacuation. And the doctors who will admit patient with tourniquet above 4 hours should think about cross trauma, which Robbie exactly talked about it, about cross trauma. So we have a patient with a loss of blood and we have a patient with a cross trauma. It means that all products above 4 hours on the tourniquets started to give us acidosis and another additional products. So, but it's just because we save lives. It means sometimes probably patients with hours will need amputation, unfortunately. Thank you. Just small comment. Thank you very much.
колеги, я передаю слово Антону. Він
So the word is given to Anton. He's going to show his presentation on medical education, how this is carried out in Israel. Anton?
Так, я з вами.
Yes, I'm here together with you. Do you see my presentation?
бачимо прохання.
Yeah, we see your presentation, but please enter the slideshow mode.
Вона розгорнута. Що ви бачите зараз?
It's on screen. What do you see now?
Антон, так само як у Робі.
Anton, the same as Robbie, you have to open your presentation completely, pressing the same sign, the slideshow mode, because we also see all your slides on the right hand side.
Зараз в мене все розгорнуто. Я не бачу в себе додаткових слайдів.
Now I don't see any additional slides. Everything is in full screen mode, and they don't know what to do. Okay, go ahead.
Вийдіть з повноекранного
Or
режиму.
maybe exit this full. We will adapt the picture in our translation. Just continue.
Це,
Just continue as is.
це що я маю робити, так чи ні?
Да, продовжуйте.
Is it what you mean? Is this what you mean? Yeah, just continue. Okay, continue. Let it be. So a few words about military medicine in general. Military medicine
10%
It's 10% of the medicine and 90% of organization, administration, and logistics.
дуже важно,
And this is
дуже
very important. This is
важливе навчання.
the education here is very important. The understanding is very important. The understanding by each person who is involved in this help and assistance at every stage. Like, and everyone should understand what was done before him and what will be done after him. This is a chain, the chain that should be continuous. And if any link of this chain drops out, breaks, then this chain will not be effective. Trauma. What is a combat trauma? For sure, there are lethal cases, immediate death cases, and there is so-called the second wave. These are soldiers with injuries who can die during the next 1 or 2 hours after the trauma. And there are also the injured soldiers who can be transported, but who can die due to the complications later on, in 1 week, in 1 month after the trauma.
Вони поранені військові.
Okay, who are the injured militaries? These are the data from Afghanistan, from UK statistics.
Лікували
According to what they treated approximately 2,000 trauma patients, and out of 2,000 trauma patients, there were 10,000 different injuries. I mean that every injured had approximately 5 traumas. What this slide should show us. The majority of the traumas are the traumas of the legs and the arms. If I'm not mistaken, Professor Pirogov mentioned that the war is traumatological epidemic. During the war, the major of traumas are the broken bones, soft tissues, injuries, etc. Head, stomach, and the chest. It's what all the surgeon likes, but this part is very limited. The majority of injuries and wounds are prosthetic injuries. Okay, what are the death factors? The death factors are the main 3 reasons are. There are several of them, and the 3 of them, the main 3 reasons that theoretically we can prevent if we provide on time, well-qualified help. Hemorrhage from the limbs, tourniquets,
прохідність дихальних шляхів,
the airway obstruction, and the tension pneumothorax.
Напружений пневмоторакс.
Ой, сліха. Sorry. Вибачаюсь. Напружений пневмоторакс.
Tension pneumothorax, yeah? Okay.
Ці причини, що можна їх...
These are the reasons that we can prevent.
Що я хотів сказати?
Okay, what else I wanted to say, and why I added this slide in my presentation. The death level depends on education, and the level of their education, I mean the level of education of those who are going to provide the help. And the death levels are going to be low in the cases when the doctor or the person who is assisting has equipment and undergone the training. Para bellum, prepare for the war. This phase is behind already. Unfortunately, as I understand, there was no time for real training and real preparation in Ukraine for the military medical staff, for the younger medical staff, because even doctors are not always understand what we are talking about and what should be done on these early stages. Okay, we talked about first two phases of military trauma, combat trauma, providing treatment during the combat, initial examination, providing initial help, initial care. And now I'd like to talk about the third phase, about evacuation, tactical evacuation care. Who to evacuate, where to evacuate, and when to evacuate. Our American colleagues joined all these issues within the term TACEVAC, tactical evacuation, that can be carried by special medical evacuation and casual evacuation. So casual evacuation, it can be by the car of your neighbor, by foot, I don't know, by horses and the rest. And the question about what is your system in Ukraine? What is in Hostomel, in Buch, in Vorzel? What is the evacuation system there? Do you have military ambulances there? Do you have Red Cross ambulances, whatever? Or it's completely volunteer process that some people are managing somehow to help and evacuate the wounded and injured? Unfortunately, I don't have this answer right now. Our US friends who are talking about tactical evacuation, they are basing their experience on the USA wars during the last decades, like the war in Korea in 1950s, war in Vietnam in 60s, 70s, Iraq, Afghanistan. And what do I want to mention here? All these wars for which the USA prepared the guidelines and for evacuation, they are talking about military actions that take part very far from their motherland. And they have a certain frontier hospital that is located in a safe place, and they need to evacuate the injured people from the battlefield to this hospital. And the distance there is unknown. That's why they're using helicopters, they're using also cars for this. The situation in Israel is somehow similar to the situation in Ukraine, because all the military actions that are carried out in Israel, they are carried out almost within the area of our country. That's why all the evacuation chains, they are built during the years they practiced, the people are trained. Every civil hospital can be switched into military hospital just within 2 minutes. From the headquarters, there is a message, the order, like from now on, this hospital is going to be a military one. And
профільній лікарні на 1000 ліжок. Кожен доктор, кожен хірург, кожен терапевт, кожна медсестра знає, що вона повинна робити.
Every doctor, every nurse knows what he or she should do at the martial law, or when we know that there will be medevac. And it means that it is true for the combat situation or the earthquake or any civilian disaster. As an example, I can give you the medevac to the hospital where I worked in 2004. And there were the situation 500 meters from the hospital where I work. The two buses were exploded by the terrorists, and our hospital was 500 away from this place. And within 30 minutes, our hospital received 102 casualties with different levels of wounds. Of course, some of them needed the high-level treatment, others were petty wounds, some were just frightened who heard the explosion. The hospital succeeded within 30 minutes to accept 102 casualties, and in 2 hours our emergency room was already empty. Someone left, others were in the operation boxes, others were under surveillance, others were on the treatment, some went to the psychological department. Why I am telling this? It can be done in this way if the hospital is trained, if every doctor, every nurse knows what they should do in the emergency situation. The second situation, within 3 or 4 hours, we received 300 casualties. These were the clash of 2 civilian trains. If you are not prepared, it is very complicated for the hospital to maintain its functioning in the combat operations. I will tell you a thing. I will not name the names and the institutions. I addressed one of my colleagues in a huge medical care institutions, which provides the surgery services in Ukraine. And I was asking him if they are willing to listen to the TCC and how to organize the process. And the response which I received shocked me. We are a very specialized facility and we are not interested in this. I still do not understand how can this be. There is no central management of the hospitals. But okay, let's stop this topic. About the evacuation. So you should evacuate the way you can. Whether you have ambulances, if you do not have ambulances, then vans, trains, horses. So if the casualty is on the battlefield, then we will not be able to evacuate him or her to the hospital where they can receive high-level treatment. High percentage of the wounds would move to the group dead. What we are doing during the transportation, we are doing the same invasions which Rob mentioned.
спостереження за
This
диханням,
is the airways, the hemorrhage, if needed, the ventilation of lungs, if needed, then infusions, if it's possible, then painkillers, everything like this.
Кого ми евакуємо та у
So,
який
whom we
порядок ми
do
евакуємо
evacuate,
цих
and
постраждалих.
in which way we
Стандарт
evacuate
НАТО,
these casualties. So there are NATO standards which say that there are 3 categories of evacuations: urgent, priority, and C routine.
Потребуючи
Those who are urgent,
евакуації, це постраждалі, що
they
є
need the urgent evacuation,
погроза
which have the threatening to life injury.
найближчі 2
And if the aid is not provided within 2 hours,
життя, втрата кінцівки, втрата
then they can lose life, limbs,
глаза.
or
Як це
eyesight.
Ока.
Ока.
Ока, забув. Постраждалі, які потребують
The casualties who are
менш
in need
евакуації, це ті,
of immediate evacuation, but not urgent, these to whom the aid could be provided within 4 hours, and then all others.
найбільш срочної, ургентної евакуації.
So those who are in need of the urgent evacuation. These are who have the tourniquets.
Наявна угроза кінцівки, він може втратити кінцівку, це іноді
There is a risk of losing a limb.
ти розповідала про це, ти питала про це. Це постраждалі з
You were asking about this.
постраждалі з
These are the casualties with
путів. Це постраждалі, яких є
with airways.
дистрес, дихувальний дистрес.
Those who has the respiration distress. Also the casualties with who are unconscious.
На поранення
Those who have
постраждалі, що перебувають у
spine fractures,
якому-небудь шоку,
those in hemorrhagic shock,
отримали більш ніж 20.
those with burns greater than 20%.
Які відносяться до категорії Б,
The casualties which belong to the group B, these are with isolated and open extremity fractures,
з травмами глазу. Я помилився.
also eye injury.
З турнікетами ще в них немає активної кровотечі. Вони
Those with tourniquets who do not have an active hemorrhage, they belong to category B. I was mistaken. And those who belong to category A, these are the saving life situation. Those who belong to category B, they have tourniquets in place. In these cases,
кінцівки, не життя.
we are speaking about saving the limbs.
У першу чергу
If there is a huge quantity of casualties, then
але не загроза
we evacuate urgently those who have the threat of to their life, and those who have the threat of losing the limb is in the second group. So if there are 4 casualties, we will not dredge them into ABC. All will be in the ambulance, and we will evacuate them at the same time. But we are speaking about 20 or 30 persons, then this should be
щодо
the preliminary triage
та решта це
about the urgency of evacuation. All others belong to group C,
допомога
the routine one.
бути відкладена на певний час.
When the medical aid can be postponed for some time.
8 правил американці
There are 8 rules,
назвали це
which the Americans called
Я не зрозумів,
8 rules of thumb.
до чого тут великий палець, ці правила
Again, I don't understand why it's called thumb.
признаків, які допомагають нам виділити
About the rules, how we have to decide on the casualties and the urgency of their evacuation.
Тут йдеться про постраждалих, що ти
We are speaking about the casualties
надає допомогу, бачиш протягом 15, 20, 30
and whom you can see for 15 or 30 minutes, and you have to take the decision within this time. So the rule number 1. Soft tissue injuries,
великі об'єми поражених м'яких тканин,
even if they look bad and the scope is huge,
це жахливо, але
it looks awful, but
більшість випадків це не
usually in most cases,
це не загрожує життю
it
миттєво.
is not a life-threatening situation.
Може бути
And the evacuation of
людина ще
these people could be postponed.
щодо евакуації пораненого повинен
This person who is deciding on the evacuation of the casualties should understand this. Then about the tourniquets which were already
Bleeding is fully controlled. Це вже казав, якщо немає кровотечі, постраждалі з турнікетами, вони
so if the casualties have tourniquets on them, then they are not evacuated urgently. So they do not belong to group A.
евакуйовані
They
через деякий час.
could be evacuated in some time.
Мають бути евакуйовані невідкладно,
Those who are to be evacuated
стану
urgently, who are in shock.
рани, проникаючи раніння,
Wounds.
поранення грудної
The penetrating wounds
що
of
приводять
the chest,
до дистресу дихального,
which to respiratory distress,
повинні бути евакуйовані якомога
should
швидше.
be evacuated as soon as possible.
Якщо навіть ігольна декомпресія не допомагає, це говорить про дуже важкий стан постраждалого.
Even the needle decompression was not effective there. The casualties
Раніння в лице мають бути евакуйовані якомога швидше.
with facial injuries should be evacuated urgently
Ще є загроза до закриття дихальних путей.
because there is a risk of airways closure.
Нахилити вперед.
The casualties should be seated and lean forward. In most cases,
дихальні путі,
it helps to open the airways and eases the breathing of these casualties.
Ми бачимо
The rule number 6.
проникаюче поранення
If
черепа
we see the penetrating wounds of the head,
розрушенням тканини мозку, навіть
whereas obvious massive brain damage,
навіть якщо він
and even the person is breathing
руками, ногами.
is still trying to move the limbs, the chance to save this casualty is close to zero.
Зрятувати такого
In most
постраждалого.
cases, there are no chances to save this casualty, and you have to move to another casualty.
Рана є, але ми не бачимо
The wound
якогось
exists, but we don't see the massive destroyance of the brain. These casualties should be evacuated as emergently as possible
нейрохірургічної допомоги.
to get the high-level
останнє
treatment.
правило з цих 8 правил
And the last rule,
та животу
the penetrating wounds of the chest abdomen
не викликають признаків
are not
хірургічного шоку або погіршення
bringing the hemorrhagic shock
стану нашого пораненого.
and do not show the bleeding
Якась повільна кровотеча, чи
that there could be
брюшну порожнину, чи грудну порожнину,
that there could be a hemorrhage inside.
евакуювати цих поранених в категорія B, вело не в
We
категорії
can evacuate them in the category B. Both evacuation could be postponed for 1 hour
цих поранених.
with lower risk to lose
Все, що я хотів розповісти. Якщо
this life. That's what I was willing to tell. If you have questions, I will try to answer.
вибачаюся за мою українську мову. Це
I'm
вперше
sorry for my Ukrainian.
20 років
It's for the first time
я
in 20 years that I'm speaking Ukrainian
2 хвилини.
for more than 2 minutes.
Це було це було
Thank you, Anton.
це була українська чи ні?
It was Ukrainian or not?
Але ні, в тебе дуже гарна розмова.
You have a very good Ukrainian, in fact.
Крамницю,
Скажеш.
крамницю
Якщо є в тебе запитання,
If you have questions, please ask. I can even say that Ukrainian problem. I believe that there will be a question. We were discussing the elements of triage, and I would love to say to Anton that the person who is involved in triage does not provide the medical aid, because now those who are dealing with triage, they are also trying to provide the care. Yes, you are right 100%. That's the separate issue, and the training
до прийому
and also the readiness of the hospital to accept the casualties.
в нашій лікарні
And in our hospital,
опитний лікар, він ще проводить
the
сортування, та він не
most
торкається,
experienced doctor
він не
is doing the triage. He is not providing care, he is just triaging them.
чомусь дуже полюбляємо термін з французької тріаж.
Like
У нас це зветься
the term triage,
людина,
we call it triage in French manner.
це найбільш
So the
важливо.
person who is responsible for triage is the most important person.
Людина, що робить тріаж. Є в нас така
There
посада,
is a
вона зветься
position in our hospital which is called
керівник катастрофи.
the
Це
head
людина,
of
що вирішує все. До
the
нас поступило
emergency
всі 100
risk management. So if, for example, we have 100 casualties and so many people are in need of surgery, so the person is responsible to decide who will be in the priority list. So I'm telling how it is organized. For example, if I receive a casualty, I'm one of the 30 doctors.
Я беру в них зразки
For example, I have my 2 or 3 patients. So I take the samples of blood.
Разрешение
Receive the permission
відправити в лабораторію, надіслати до лабораторії ці зразки крові.
to send to the laboratory these blood samples. And I receive the decision only from this person who is responsible for risk management during the disasters, because only he knows how many surgeons they have and how many X-ray equipment they have. Do we have the queue? So it works in this way. It cannot function in different operational models.
Ми це називаємо балаган.
In Hebrew, we call it balagan.
Таке дуже єврейське слово.
It's a very Jewish word. Thank you, Anton. We are trying to go the same route, but usually our doctors are acting in a different way. As soon as they see the casualties, they are trying to provide the care. After the victory, we will talk about this. There should be a training program. If we have these things going on,
Папку номер 3 відкриваємо на сторінці номер 5.
so we just take the file number 3 and open at the page 5 and are acting following. But I would like to say Ukrainians are very good, so they are in the severe conditions, and our military, they are great, and the doctors, they grew professionally a lot. They are very cool, and all around the world see this, and it's very good that our colleagues support us. And the Ukrainians are very thankful to the support and to everything you do. That's what I can add. But the doctors in Ukraine grew professionally a lot in the last years, and they are heroes in their. We will meet at 7 o'clock in the afternoon after the war. Dear colleagues, I'm thankful to you for this beautiful webinar, that you found your time. Unfortunately, Rob had to go to work according to the difference in time. So I hope that this webinar was necessary to you, that it was helpful not only to the doctors, but also to others who are now suffering from this awful war. And I hope that we will have the chance to meet. We will talk more about the next hospital stage. Goodbye. Thank you, Kirill, for organizing this. Thanks. Thanks to everyone. Everything will be Ukraine.